So the postMONARCH study was a global phase 3 trial that was addressing the question of whether we should continue a CDK4/6 inhibitor upon progression and switch the endocrine therapy. We'd seen from other phase 2 trials some inconsistent findings in terms of the potential benefit of this approach. And so the postMONARCH study was a trial of around 368 patients who were randomly assigned to fulvestrant plus abemaciclib versus fulvestrant plus placebo immediately after progression on an aromatase inhibitor and any CDK4/6 inhibitor. So the study design was for patients, men and women, hormone receptor positive, HER2 negative advanced disease, no prior chemo in the advanced setting, no prior surge, and 368 patients were randomly assigned to fulvestrant plus abemaciclib versus fulvestrant plus placebo after progression on any CDK4/6 inhibitor and endocrine therapy. And the primary endpoint was investigator-assessed progression-free survival. So we assumed a hazard ratio difference of 0.7 in this study. This was a statistically significant study, so it met its primary endpoint. We saw an improvement of progression-free survival with a hazard ratio of 0.73. So the study demonstrated that this is a strategy, continuing fulvestrant plus abemaciclib after progression on hormonal therapy and a CDK4/6 inhibitor. We saw a few things in this study. So one, if we look at the overall results, the control arm, Faslodex alone, did better than what we've seen in other studies. And this may be due to this is a very endocrine sensitive population. And this was a true second-line study, and patients were not allowed to have prior chemotherapy in the advanced setting. The other findings are we, saw some well-represented subgroups, including those that did not have visceral metastasis and those that were on their prior CDK4/6 inhibitor for greater than or equal to 12 months seem to be subgroups that seem to benefit in particular. For instance, we saw a 5 to 6 month median PFS benefit for those without visceral metastasis, though there was a numeric benefit of about 2 months for those with visceral metastasis. The other thing that's notable is that in exploratory analysis, we looked at baseline circulating tumor DNA, and regardless of the presence or absence of ESR1 mutations or PI3K alterations, there was benefit with this strategy. And so this has demonstrated this is a strategy for some patients. Of course, we have other second-line options as well, but this option is regardless of the presence of biomarker positivity. For the next steps for the postMONARCH study, we hope to report additional subgroup data, including additional biomarker data from the postMONARCH study. So that should be presented hopefully at some additional congresses this year. And I'll also just mention that there are other studies that are looking at this approach that hopefully we should see the results of soon, including EMBER-3, which is a study of around 850 patients that randomly assigned patients imlunestrant versus physician choice endocrine therapy versus imlunestrant plus abemaciclib. So more to come about this potential strategy.